My case is a 73-year-old female. She smoked until 3 months ago. She's known to have systolic hypertension, which is quite well controlled. And 3 months ago, she experienced an inferior posterior ST elevation MI. She underwent primary PCI, and she received a drug-eluting stent in the first marginal branch, the obtuse marginal branch. She has mild to moderate LV systolic dysfunction. She has residual moderate coronary artery disease in the anterior descending and RCA. She has no angina, and she's a New York Heart Association class 1. So a 73-year-old female with a drug-eluting stent who underwent primary PCI 3 months ago. Her medications, she received prasugrel for ST elevation MI. She's receiving aspirin. She's receiving ramipril for secondary prevention and a beta blocker and a statin. She has normal renal, hepatic, and thyroid function, and her lipids have been normalized using atorvastatin. She came to her physician experiencing palpitations, and her resting ECG showed normal sinus rhythm with tall R waves in V1 and V2, indicating a prior MI, but then she was sent a 24-hour Holter monitor, ECG Holter monitoring, which showed recurrent episodes of AFib with a maximal response of 130 per minute, maximal duration of 23 minutes, and a cumulative duration of 69 minutes. So this is a female who has symptomatic AFib, and she's 3 months post-MI with mild to moderate LV dysfunction. These are the medications she's receiving, which is, by the way, quite common for ACS patients. So I have 4 questions to the panel, and the first question is, do we need or should we add an anticoagulant or stick to dual antiplatelet therapy with prasugrel and aspirin?
So this is an interesting case. Obviously it's not a clear-cut case one way or the other. So if we want to address the question, does she need an anticoagulant, we need to stratify her, and she would be, if you use the CHAD score, she'd be a CHAD 1, hypertensive, not 75. If you use the CHAD VAS score, you probably see the advantage of the CHAD VAS score, because here she has 2 of the additional risk factors. She's over 65, and she's also female, so she's now in a with CHAD VAS score.
And vascular. She's
And vascular disease as well. So she's definitely in a higher CHAD VAS score range, which would suggest that perhaps, according to European guidelines, that she should be 85 with it. However, we do need to recognize that this is not a standard situation. It's a situation where you're going to be adding anticoagulant therapy to dual antiplatelet therapy. So you certainly want to be more, you would have, I think, a higher threshold for wanting to institute anticoagulant therapy, because we know that combining anticoagulants with dual antiplatelets has a much higher risk of bleeding than anticoagulants alone. So, would you add an anticoagulant here? I think that I would probably not add warfarin here, because I think that the risk of adding warfarin in terms of bleeding would probably be outweighed by the risk of hemorrhage. And dual antiplatelet therapy is an effective treatment for stroke prevention, and certainly more effective. I wouldn't switch it to clopidogrel in that situation.
Well, that'll be the next question. Anyone from the audience has a different opinion? Would anyone add an anticoagulant at this stage? Do you want to address the issue of the cumulative duration of the AFib?
That's also another interesting question. First of all, I'm surprised that no one has a different opinion. I think it would be quite easy to make a strong case for using warfarin in that situation, and many people would. So I think it's a borderline situation, and certainly the European guidelines are pushing us to consider warfarin therapy more strongly in setting. So I don't think it's a clear cut one way or the other. So I'm just trying to make the case that speaking to the people with disaster would not be unreasonable in this situation. Also, going to an anticoagulant, perhaps the patient's preferences would have to be taken into account. To what extent are they willing to risk a hemorrhage in order to prevent stroke?
My question really was, how much information is there on the combination of dabigatran together with aspirin and prasugrel
We'll get to this in the next questions, okay?
Just a comment on the duration of atrial fibrillation. We don't know how long atrial fibrillation needs to last for in order to confer a risk of stroke. So we're talking about one Holter monitor showing several minutes, what is it, almost an hour of cumulative atrial fibrillation. Is that long enough to confer a risk of stroke? Well, we don't know. And if you have that much atrial fibrillation on one Holter monitor, what if you monitor it for a month or for 2 months? How much atrial fibrillation are you going to see when you do that? We don't know. A lot of pacemaker studies tell us that, in fact, we see a lot more than most patients who don't feel their atrial fibrillation. This patient probably has quite a lot of atrial fibrillation. I would be inclined to feel that that much atrial fibrillation on a Holter, on a single Holter, is going to be indicative of a lot of atrial fibrillation and a significant risk of stroke.
Okay, so my next question was, you said that you would go with dual antiplatelet therapy and switch the patient to clopidogrel.
I never said that.
You said clopidogrel.
If my choice was warfarin, then I would probably stick with dual antiplatelet therapy. But my choice isn't warfarin.
Okay, but if you would stick to dual antiplatelet therapy, would you switch the prasugrel? Or if you would add an anticoagulant, would you stay with prasugrel or switch to clopidogrel?
If you're going to go with dual antiplatelet, then you should switch to clopidogrel because clopidogrel has been shown to reduce the risk of stroke on top of aspirin by 28%, which prasugrel has not. So clopidogrel is now indicated for stroke prevention in several countries, including the European Union and Canada, and is a reasonable treatment in the setting that prasugrel is not.
Okay, and if you add an anticoagulant, no matter which one it will be, would you switch the prasugrel to clopidogrel also, or would you add it on top of prasugrel?
I don't have an opinion on that. I mean, probably switch to clopidogrel at this point, just because I think the bleeding risk of clopidogrel is a little bit less than prasugrel.
Okay, any other opinion? Avi Kaspi, you always have an opinion, so how about now?
I think that the main point of interest to me is really the emotion. How we got the fact is really important and that is important. I don't think we have enough data about it. And I think, like I said, the very beginning of the regulation, I probably in this situation would be on top of and probably switch to the thing because I think the practical is really and then try as far as I can to go back to
Okay, so if we say that you're more inclined to give an anticoagulant, would you give the dabigatran or warfarin? And I just to make it a bit of an issue, you mentioned the fact that with the dabigatran, there is the issue perhaps of more MIs. So in this case, would this be an issue for you? On the other hand, if you're continuing to do antiplatelet therapy, maybe the safer profile with the dabigatran versus warfarin. So how would you weigh this?
Well, I think that there's a clear advantage to the big trend 110 in the setting. I mean, what we're worried about here is the downside of antithrombotic therapy, which is bleeding. We want to be able to treat this patient, but we want to treat her safely. And the one antithrombotic therapy that has the best bleeding profile is the big trend 110 and significantly reduces the risk of stroke compared to risk of bleeding compared to warfarin and has comparable efficacy. So I think the big trend 110 makes a lot of sense here and is clearly an advantage over warfarin and makes it easier to reach for an anticoagulant in this patient and continue to do antibiotic therapy. So the evidence that we have from the RELY study is that there's an increased risk of bleeding with all antithrombotics in the presence of aspirin and clopidogrel, and it's about the same increase, and so the big trend 110 has an advantage.
So if you go with the Bigatran 110, I would ask you again two questions. One, are you not bothered by the fact that the Bigatran, the association with the Bigatran and MI, and are you not bothered by the fact that the Bigatran 110 is not approved by the FDA? I think that's one of the things that's stirred up a lot of commotion.
So in terms of the risk of MI, mean, I think that I made it fairly clear when I presented the slides that I think that it's still questionable whether there's a true risk of myocardial infarction or not with the big trend, but there's no doubt that it reduces hemorrhage. So, on balance, I think the hemorrhage outweighs any concerns about increased risk of MI. And the, the, the fact that the big trend 110 is not approved in the U.S. would have absolutely no influence on me. And indeed, their rationale for not approving it was laid out in the New England Journal article where they, I don't know if you read that came out a couple of weeks ago, where they clearly acknowledged that this is an effective dose and is useful, but the only reason that they didn't approve it was that they have something even better, which is the big trend 150. But what they didn't explain was what does that mean for another drug that comes along that's just non-inferior to work and with reduced bleeding, such as rivaroxaban. I mean, they won't approve that because they have the big trend 150. It's not a very logical approach to take. And it certainly doesn't address the specific setting where you have an increased anxiety about bleeding. You want to choose a dose that is relatively safe and in a patient who is not excessively high risk for stroke. This is only a moderate risk patient.
Okay, and maybe someone from the panel or you, do you want to address the point made by Johnny regarding triple therapy with the Bigatran, the REDEEM registry maybe, if anyone wants to. Well, there is a registry of anti triple therapy with the Bigatran, and the results are quite promising. The event rates are very, very low, hemorrhagic event rates. There are thousands of patients already enrolled.
They communicate with the other individual for 75 milligrams of the bigger drug, which to me doesn't make any sense. However, is it an option in this patient?
I don't think so because in the 75 milligram BID dose of the bigger trend was specifically for patients with severely impaired renal function with infractive nerves between 15 and 30. And in those patients, it makes pretty good sense because you can do modeling from the kinetic pharmacodynamic data for Y and predict plasma concentration in those patients.